a very warm welcome to all of you who've joined us for the live activity tonight. And we've had an extraordinary number, over 2,500 registrants, which is a huge number, and I suppose is really a testament to just how important this area is for clinicians. Very warm welcome also to those of you who are watching us later on a recording, and of course a warm welcome to our panelists who I will introduce to you in just a minute. First, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panel and our participants are located, and I'd like to pay our respects to their elders, past, present and future. My name is Mark Creamer. I'm a clinical psychologist in private practice and a professor in the Department of Psychiatry at the University of Melbourne. And I've had a very long interest in the mental health effects of trauma, and particularly in veteran and military mental health. And of course, in my clinical practice, suicidality is something that inevitably comes up from time to time. And it's something that I think a lot of people always find challenging. So it's a great pleasure and honor for me tonight to be facilitating this panel and to have the opportunity to draw on the expertise of our expert panelists. So without further ado, let me introduce them. Their bios were disseminated earlier, so I won't go into all the details. But first I'd like to introduce Grant Blaschke, who is joining us from Melbourne. Grant is a very experienced general practitioner. He's also lead clinical advisor to Beyond Blue. He's an associate professor at the University of Melbourne, and he has a very strong track record in education, in policy advice, in research and program evaluation. Welcome, Grant. Thank you very much for joining us tonight.
Thanks very much, Mark.
I was really interested to see that you make regular trips to China to train their GPs. Do I infer from that you're fluent in Mandarin?
No, I'm certainly not fluent. I've been learning, and my Mandarin's still pretty rudimentary, so I have a translator with me. But I really enjoy going over there a few times a year, and the GPs are super keen to learn some GP skills.
Well, that's great. And I must say, I was going to ask, do you feel that our Western model of GP health, if you like, fits okay within a Chinese culture?
Look, I think it has elements, but I think the Chinese will very much shape their own approach to primary care and general practice and take the best bits, I think, of what we can offer here, hopefully, in Australia.
Yeah, good. Okay, well, thanks very much, Grant, and welcome. Our next panelist is Carmen Betteridge, joining us from Sydney. Carmen is a psychologist and Director of Suicide Risk Assessment Australia. So she is ideally placed to be on our panel tonight. She's also a member of the International Committee for Guidelines on the Impact of Client Suicide on Clinicians, on workers. And that's clearly a really important topic and something that we'll be coming back to later. So welcome, Carmen. Thanks for joining us tonight.
Thank you for having me.
Clearly, this is a pretty heavy topic, so let's start with something light. I'm a very big fan of homemade chutneys and jams and preserves and things, but I've never had the courage to actually try and make any myself. But I hear through the grapevine that you're something of an expert on this.
I do like making chutneys and jams and having preserves. I'm a bit of a fan of the old skills. So yeah, favourite is probably fig and rhubarb, actually.
Fig and rhubarb chutney,
yeah.
I suppose.
No, jam. Fig and rhubarb jam. Yeah.
Wow. Okay, well, sounds great. And I'd love to talk further about that at some point. One of the things that struck me, and I guess we'll talk soon about self-care for clinicians, but the importance of actually having some kind of meaningful hobbies and activities to take you away from work is probably going to be pretty important, isn't it?
Absolutely. Yeah.
Yeah. All right, thanks, Carmen. Our final panel member tonight is Richard Magnant, joining us from Perth, where he's a psychiatrist and director of the Trauma Recovery Program at the Marion Centre. Richard served for 10 years as a commissioned officer in the Royal Australian Navy before making the switch to medicine and later psychiatry, and he maintains strong links with the ADF. Welcome, Richard. Great to have you with us.
Thank you, Mark, and I appreciate the opportunity to be here, and good evening to everyone.
Right. That was an enormous career change for you, wasn't it? And I just wonder what led to you switching from being a marine navigator to going into medicine.
I think at the time it was more because of some experiences I had within the Navy, but also upon reflection, excuse the frog in my throat, it was wanting to do something that was more congruent to my personality, which was rather than spending time practicing for the theatre of war in a maritime environment, I wanted to move towards the healthcare professions, and so I went off to do medicine at Queensland.
And what was it a difficult transition for you?
Very. Even though I went from one hierarchical structure of the military to another, in medicine you have the commissioned ranks of sort of professors down through to interns, medical students, and non-commissioned ranks of the senior nurses down more to the enrolled nurses and the orderlies, which mirrors the military. The chasm that you jump out of everything being prescribed through defence instructions. I mean, even a barbecue has an itinerary and a list that you have to do in the military, to moving into the civilian sector where you have to be far more autonomous and show greater self-agency. It was a surprising challenge to that first year.
Yeah.
And when people talk about that, it certainly resonates with me leaving the military, the difficulties for them.
Yeah, we have one of these webinars later in the year is actually on transition, and I think that we might touch on it tonight. So I'm interested that you have that experience. Anyway, thank you, Richard. Thanks to all our panelists. If you'll bear with me, I'd just like to spend a minute to tell you about the webinar series. This is the 7th in a series of DVA commissioned webinars on veteran and military mental health. Last year we talked about veteran and military culture, we talked about PTSD, anger, sleep, substance abuse, families, those kinds of things. And if you missed any of those, all of those are available from the ATEES website, the DVA ATEES website. So do follow them up. And today is the first of this year's webinars, the first of 4 webinars this year. And of course, we're going to have a look at suicide. Now, you've all had a chance to look at Craig's case study. We're going to use Craig's case study as a kind of platform, a jumping off point to help us explore some of the issues around suicide. And my guess is that on reading about Craig, he probably rang several bells for many of you about your clients, particularly perhaps your veteran clients, but also others in your client population. So the idea of the webinar, the learning outcomes, are that through a discussion around Craig and the issues that he raises, that first of all, at the end, you'll be better able to recognize the risk protective factors, warning signs, that you'll be better able to describe the supports and the resources that are most effective, and that as a result of both of those two, you'll have increased confidence in supporting veterans, families, partners, and so on, who are thinking about or experiencing suicide or attempted suicide. So in terms of the format for tonight, each of our panelists is going to give a brief presentation looking at their unique perspective of Craig's case and the issues it raises for them. And then after that, we'll open it up into a general discussion. We'll address many of the questions that you've sent in and have a broader discussion about the area. So without further ado, let me hand over to our first panelist, Grant, to talk about a GP perspective. Over to you, Grant.
Great, thanks very much. Well, I'm really delighted to participate in this. I mean, we want to see the best mental health care we can for our servicemen and servicewomen, and to provide a little bit on a GP perspective, I'm just going to make some brief points. Firstly, that GPs are in general highly trusted. We're a pretty low stigma option, usually pretty accessible. We also often have intimate knowledge about the local culture, and I mean culture in a very broad sense. We know local families, what services are available, who are the best people to refer to in what situation. And the other point I wanted to make is someone like myself would be pretty typical of the GP that a veteran may be seeing who won't have any military experience. And so I just wanted to make that point as well. Second point I want to make is that GPs do straddle physical, mental, and the social realms. And I think that, you know, in the case of Craig that we're all looking at, you know, he comes along with physical concerns, pain, mental health issues, and also the GP has some knowledge about his parents as well. And this is pretty typical about the role of the GP having that very broad perspective. So the next point I want to make is to do with access to mental health services. And the reality is that access varies widely across the country. If you're in inner urban Melbourne, as I am, I can usually get a pretty quick specialist response if I need it. In other parts of Australia, it's going to be pretty hard. And I think for GPs to be caught in the situation in this case, a big factor is whether they know that they can get the help when they need it. I think GPs have a really important role in long-term recovery, and we're going to talk about that a bit more in detail later on, but scheduling regular consults, mobilising family, helping patients get back to routine, managing the mental health problems, sorting out the physical problems and dealing with any substance abuse problems. So this is a pretty typical list of things for the GP. So to summarise, there's the short-term safety issues, but in the long term, I think the GP's got a key role pulling the team together. The final thing I'll say is I think for the GPs out there and for others as well, having some knowledge of the different services that are out there is really important. You know, things like non-liability healthcare, which we might talk about, the various websites and phone supports. So I'm going to keep it short and just stop there, Mark, and hand over for our next speaker.
Thank you very much, Grant. That's wonderful, coming in under time. That does wonders for my anxiety levels, I must say. Thank you very much for that. But I wanted to talk about time, actually. GPs, I guess, are often very short of time. They're under a great deal of pressure to, for want of a better word, to churn people through fairly quickly. Do you think that most GPs do have enough time to be able to address these kinds of issues?
Well, I think you're exactly right, and I think me finishing on time tells you what profession that I come from. We are used to rushing and moving through things and not running late. But look, time is a big issue. There's quite a lot of research shows, you know, if you don't have enough time, it's very hard for GPs to manage complex mental health issues. There are Medicare incentives for GPs to spend more time with patients, particularly if they've done extra mental health training. But you point out, and I'm sure the GPs who are listening will agree, it's really hard to do anything constructive in under 20 or 30 minutes. And this can, you know, depending on your financial and scheduling setup at your practice, can be a really important issue.
Yeah. Although I was struck by the point you made on one of your slides to make regular appointments. So maybe you don't feel that you have to get through it all in the first appointment. You can tee up something else later in the week, perhaps, on occasion.
You're exactly right. So we can do things in small bites, and a broader issue is, I think, as a GP, booking a regular appointment so that people are coming in without having to have a particular symptom is a really valuable intervention where the GP is really saying, look, I'm there and I'm available and I want to see you every week.
Great. All right. Thank you very much indeed for that perspective, Grant. And of course, we'll pick up on many of those issues when we broaden out for a discussion. Now, though, let's move along to a psychology perspective and perhaps get a look at some of the research and the literature around clinical practice and hand over to Carmen. Over to you, Carmen.
Hi, everyone. I guess to start with, one of the points I'd like to make is that suicidality is not a fixed or permanent state. So in looking at the diagram from Wasserman in 2009, this sort of highlights the fact that there are things that we don't observe, so ideation, but that when we see stress points coming through, that's when we might have escalation. And equally, we can see factors including the overlay that this can take is with the fluid vulnerability theory, and that provides some information from Rudd that looks at where the fluctuations happen, that suicidal crises are time-limited events, and that those crises can occur with the presentation of a stressor, but equally with the removal of something as a protective factor. And that our assessment processes need to really incorporate, I guess, looking at suicidality as a fluctuating process. Jacinta Horgood and Diogo DeLeo have written several articles that I recommend viewers to take a look at later on regarding that point. In looking at the interpersonal theory of suicide, Thomas Joyner has looked at three key components to suicidality, being thwarted belongingness and perceived burdensomeness as, I guess, presence for the desire for suicide, but it has to be incorporated with a capability, which is through exposure and access to means that the capacity for suicide emerges. And for Craig, we can see that his perceived burdensomeness with the injury and the belongingness as well, having left the military, and then the capacity being the access to firearms in the context of a pain, a persistent pain condition. There's a lot of research around risk factors, and I'm not going to go through the several dozens of chronic and acute risk factors present. What I would like to point out is that for each individual, we have to take a person-centred approach. So risk factors are often unique to the individual, although we use big data to say factors such as substance use history, psychological disorder, and physical health conditions are often risk factors to take with us. Really important to note are those risk factors related to prior history of suicidality. In saying that, there's some military-specific risk factors that I just wanted to highlight, and they are things like military personnel are more likely to die on first attempt than the general population, but traumatic brain injury and post-traumatic stress are also identified as increasing the risk for suicide. That in some, and this is US data, not Australian data, but the US data has said that for some there are of lower rank or in special operations or in commanding, high command positions with a number of deployments, they're also at increased risk. With respect to warning signs and Craig's factors, we can see these warning signs as suggesting imminence of risk, and this is the value of warning signs rather than risk factors, which don't give us any imminence or utility in saying how urgent our interventions are. So for Craig, the withdrawal and the increase in drinking, when we see the next layer, which is he's starting to handle a firearm, he's starting to think about death more regularly, those warning signs are really saying that his risk is emerging far more significantly. We need to intervene immediately. In terms of our assessment has to be really in-depth. Our assessment has to follow the narrative, and that provides the information about means restrictions. So first of all, taking a look at the removal of the firearm, but equally asking questions about his access to medications and his other thoughts around suicide. We can then from that also work to develop a good safety plan, engage other parties, whether that's his parents, other VDCS people, or people who he trusts. In terms of treatment, I guess there's three key ones which we can talk about: CBT, suicide prevention, CBT, and CAMS, and they're the ones that have had randomised controlled trials and are proven to reduce suicidality. Of course, also looking to treat comorbid conditions, whether that's substance dependence and depression for Craig, and also looking at that collective kind of approach, using family, using community, using the services from Veterans Affairs. But ultimately, what I wanted to finish my presentation on was the fact that working in this environment does have an impact, and that impact can be quite significant. So for anybody who's watching, thank you very much for viewing, but also look after yourself. Thanks, Mark.
Thank you very much, Carmen. And yeah, that last slide there about self-care I think is really important, and I would very much like to come back to that in a bit more detail when we talk about the discussion, or at least some of the major components of it. One of the things I did want to highlight, though, was I was chatting to a young vet the other day, not in a clinical role, but in another setting, who had been very suicidal, and he talked about the safety plan being the key thing that kind of got him through. Can you just tell us a bit more about that? What that might look like, or how it might work?
So the safety plan, and I guess it's important to know that it's an evidence-based process that was implemented from Stanley and Brown in 2008. They first started doing it with their people who were on a waiting list. And they were looking at essentially short-term interventions that the person could do themselves, and also how they can engage others to support distraction or that sort of thing. But it has to rely on the client recognising their increased agitation or some of the warning signs for themselves. So with Craig, for example, we want to first of all look at what his signs are, his levels of agitation, whether he's been sitting for a long time thinking about suicide, or just taking his life generally, death, that sort of thing. So it's recognising that, and then looking at what strategies he can put in place that can distract him or that can alleviate that distress. And maybe that's reaching out to someone else, and at the end of the day it may well be that he contacts a a 24/7 line like Lifeline or Suicide Callback Service or the VDCS, and I guess get some immediate support. A safety plan could be short or long term, with the number of sorts of interventions that you want to put in place.
And presumably we go as far as having a little card for him that he is in front of him, and all the numbers are there, and so he doesn't have to think it through or look anything up. It's there.
Definitely. And it can be a card, it can be there's also apps, and there's a whole range of safety planning kind of strategies out there. Yep.
Right. Okay.
Mark, if I may comment very briefly, just to say that Beyond Blue has the Beyond Now app, which a lot of my patients find quite useful, and which sort of structures some of this process. And as you know, people have always got their phone in their pocket now. So just to mention that.
Great. Okay. Thank you very much, Grant. Thank you very much indeed, Carmen. And let's now hand over to Richard for a psychiatry perspective on Craig's case. Over to you, Richard.
Thank you very much for that. And again, good evening, everyone. I guess as a psychiatrist and having spent a lot of time dealing with veterans, the central aim of what I try to do is, as stated in the previous slides, is to destigmatise the experience and normalise it, that anyone going through significant challenges or a particular juncture in their life that's overwhelming can certainly feel that life is not worth living, and they may develop a belief that suicide is indeed a relief of suffering, maybe the driving force. I often draw on pictures and I give them to the veteran and the family. I'm a big believer in that you have to treat the family within which the veteran's living, are our greatest resource so often. And using the example of the green zone, yellow zone, and then the red zone, and just trying to normalise it for veterans to what thriving, normal functioning might look like through to common reversible distresses, changes in behaviour, and then significant functional impairment. And I sometimes circle those areas, and then it can be used as a scaffolding to discuss how you want to get people back into the green zone, and you can also have them chip in with that. And it can be very very palpable in terms of the experience of observing them, seeing these sorts of tools to realise where they have come from and the time frame that it's occurred and where they may want to get back to. In terms of my perspectives, I follow Antonia Murphy's belief in breaking the dichotomy and enlarging our view, even if only by a tiny chink, where there is this palpable sense in the veteran that they are without hope. And there's been many times that I've said to veterans, I will carry the hope for them until they're ready to take it back. Now, in terms of our case study, what's most palpable to me is anger, and I strongly believe that anger can either kill or it saves the person's life. But as part of that inquiry, if we ask simple, crisp questions of high yield that people can basically wrap their own explanations around, such as where and how are you hurting, what are you feeling, what would help you right now, and what it is you feel you must solve or get out of, and what would it take to keep you alive, what is the least worst possibility that you could potentially bear. So getting straight down to the heart of their difficulties, obviously once trust and rapport has developed, it's not something you do initially. And if there's ever been any situation similar to this in the past, and how did they get out of it, or what would they change if they could this time. Unfortunately, as a psychiatrist, and probably many clinicians who we're spending time with this evening, we all have our own graveyards. And my first few patient suicides certainly made the reading I did on Colin Murray Park's work on our assumptive world resonate even more strongly, in that when a patient ends their life, it shows that our own naive or self-aggrandising assumptions of what a strong and capable clinician we are untenable, and you can feel quite impotent in that setting. And the second paragraph on that same page that Parks or Murray Parks speaks to, I believe that if I'd cared enough about my patients, they would be safe if I loved them enough that everyone can be helped. I just needed to be able to say the right things and I'll keep my patients safe. And unfortunately, that's not the case, particularly in the area of men who are veterans who may have significant comorbidities such as alcohol abuse, they may be alexithymic, they may have difficulties understanding and naming their emotional states. There's a number of things that we work against, and I think that the great tonic in that situation is normalising the experience, developing trust and rapport, and involving families. But as was said before, it's really important that we are aware of the potential of vicarious trauma in all of us, because it certainly occurs. I undertook a root cause analysis when we had a few adverse events within the hospital I work in some years ago to understand how we could resolve these problems in terms of the systemic treatment of the suicidal patient or the patient at risk. And we determined that building the best way for rapid access to care for ADF personnel or veterans with a fast response time was critical, particularly in the higher risk clinical situations. And better communication between all stakeholders, the EVCS, the general practitioner, the GPs are pivotal in my mind, absolutely pivotal, and particularly if there's a previously established relationship before the crisis declares itself. Allied health professionals and some ex-service organisations. Overwatch is an excellent organisation, as is Veterans 360s, and mindful of time, I'm happy to speak to those later or provide some resources. Integration across sites of care to share the risk is very important, as is a robust discharge plan with early follow-up. We know that many suicides happen within the first 5 days after discharge, so it's really important that there's even telephone contact to see how someone's going, or asking family to wrap their care and support around the veteran or the defence member as appropriate. And just finally, in terms of mental health treatment, not all but many patients will experience underlying mental health conditions which require our vigorous and assertive treatment. And effective treatment of these conditions is essential to reduce the chance of relapse and future suicidality. And we need to assertively engage Craig in evidence-based treatment, which is biopsychological and social, but also, if we can, within the veteran community. And then careful follow-up and monitoring is really important. Thank you.
Great. Thank you very much, Richard. There's a whole multitude of issues raised there that I really want to come back to later. So I'm going to put a whole lot of them on hold for the moment, including those peer support kind of issues. I've got a couple of questions now, one quick and one longer, but the very quick one is, on your slide about fast response times, you had DAN, D-A-N. What's that?
A defence activity number.
Oh, right.
If there's one thing that I could ask people to take home tonight, it's to consider, as part of your service planning, who is locally available to provide a rapid in-reach service to go to the person's home, and where is the best place for their disposition planning. And within the private setting at least, DVA provides defence activity numbers, and if you're an accredited site of care, it's very quick for a GP or Joint Health Command, anyone who provides care for veterans and defence members, to say, we need a bed. And in our hospital, I'm very well supported, because if it's a veteran, first responder or defence member, that person goes straight to the top of the wait list, which I think is important. So minimal wait for beds. You could imagine that an ambulance or police officer is the last thing they're going to want to do is walk through an emergency department and say hello to their friends on the way to be treated, because they've experienced a very challenging period in their life. So if we can get them into the private setting quickly, that's a good thing. And we have a number of affiliations, so just streamlining that process, and then training your nurses within the hospital and identifying people who have an interest in veterans' mental health, and then focusing the veterans' care with those staff members. You don't want to be doing this stuff on the run, clearly. It's good to have done some service planning around it. Absolutely, and that clinicians have that kind of that kind of information at their fingertips, so that they can move fast. Great, thank you very much, Richard. Thank you very much to all three of our panelists for that discussion, and thank you particularly for your timeliness coming in on time. I very much appreciate it. Okay, so now we're going to move on, and we're going to move on to the general discussion, the questions and answers, and I'm going to ask our panelists to just jump in and add comments and perspectives. It's okay, to disagree or add alternative perspectives with each other, so that we'll try and run this as a little bit of a conversation, a little bit of a discussion. But we're going to use a lot of the questions that you as participants have sent in, and I have to say that I'm very impressed by not only the number but also the quality and the
the depth of the questions that you sent in. So we'll try and get to as many of those as we can, but please bear with us. There was a huge number coming in, so we won't get to all of them, but we'll get through to as many as we possibly can. However, to help us prioritize, what we've done is to divide the questions that you sent in into 5 core themes, and we're going to give you the opportunity to vote on which of those themes you think is most important, and that will help me guide the discussion so that we can spend more time on the areas that you're most interested in. We will cover all 5 of those areas, but it will give me a bit of a guide. So if I can ask Jan from Redback to start the poll, please. You'll see a screen come up, and it should give you an opportunity to click against the one that you think is the most important. You've only got 30 seconds to do it, so don't hang around. Do get onto it. But it will, as I say, give me an opportunity to think about where we should put most of our time. So just have a think about what you think is the most important. I'm just going to give you another few seconds, and then we're going to call it a day. Okay, good. So if I could ask Jan then to close the poll, and if the technology allows, I'll get you to put up the results for everybody to see. But I can see on my screen that the one that came out highest was management and treatment modalities, and I'm very pleased about that because that's the area that I think we should be focusing our attention on. So we will spend most of our time on that. But we did have a fair bit of attention to each of the others, so we will make sure that we address those as well. Even though I think we did rate management and treatment modalities the highest, I think I would like to go through them in order because it just makes more logical sense. So if you'll bear with me, we'll go back and talk a little bit about risk and protective factors to begin with. And I thought I'd just like to start a little bit with whether, in terms of risk factors, I guess this is one for you, Richard, in particular, given your comments earlier, that the process of transition is a difficult process, and whether or not we can interpret a lot of Craig's problems as being something of a failure to adjust to the transition, and whether you or indeed the others have any comments about whether perhaps if his transition had been handled better, he might be less at risk of suicide now. Do you want to comment on that?
It's a difficult question, and I'm going to be careful not to get on my soapbox. I think the Defence Force, unfortunately, is one of the organisations in Australia that doesn't adequately cover life after ... done in sport, AFL, the Australian Institute of Sport. And the Defence Force, even though most people spend not more than 7.5 years, depending on the research, very little discussion is made on what are you going to do when you leave the Defence Force. Having spoken to a lot of veterans, it's still very much the same. When you first go to recruit school after enlisting, the first 4 to 6 weeks, you have, as a privilege really, ongoing contact with family and friends, and there's a real acculturation into the Defence Force, and it's sort of an us as defence members and then a them as civvies. And that happens for the better part of a decade. The itinerant posting nature of defence makes it more challenging to maintain sporting groups, friendship groups, so that those deep roots that you have from your pre-defence life can sometimes be pulled up, and then you are transplanted back into the civilian world. And whilst you're coming to terms with practical day-to-day issues regarding monies and dealing with any potential traumas, mindful that most people who get out of the military have no problem at all. And, you know, the most usual outcome of trauma is nothing. It's an adjustment to it because of resilience. But a lot of people who we see, obviously, in this setting have a real paucity of support. Those that they do have are often very strained or don't understand why this person is walking around like a bear with a headache and everyone else is on eggshells. The transition is very important to talk about, in my mind, from early in someone's defence career, and it's something that other people may or may not think is relevant, but I would imagine that if people have retained their friendships and then when they go back to their home, wherever that might be, that they will thread back into civilian life more easily. And you only need one or two good friends that you've maintained a relationship with to help at the most difficult of times. We all know that.
Okay, so it may be that had a bit more attention been paid to those kinds of issues with Grant, he might not have quite found himself in the situation that he is today. Just to give a minor plug, I'm actually running another webinar tomorrow for VVCS, and we're talking about transition. This series of webinars also with MHPN, as I said, are talking about transition. So there's a lot of really important issues you've raised there, Richard, that I think we need to come back to. Nevertheless, Craig is now in the situation in which we find him. And thinking about risk factors, I don't know whether to ask Carmen or Grant, but he is drinking a fair bit. Perhaps I'll turn to you, Carmen. Do you think that the alcohol use is a significant additional risk factor for suicide for him?
I do, and there's two layers of this. There's the current drinking that's the concern in terms of his potential use, and I'd like to engage him in understanding why he's using alcohol and what he thinks he's using alcohol for, whether or not he's started using it for social lubrication and it's transitioned to coping. But it is a disinhibitor, and it does increase impulsive actions, and it does have the ability to make thinking around suicide quite concrete. So during intoxication, that's a concern, but over a period of time, if he's having some experience where he's becoming dependent, there might be factors such as withdrawal, aspects that are increasing his agitation, which he's not conscious of. If he's gone through a prior experience, and I guess in the long term when people have had substance dependences and they've fallen off and gotten back on the wagon and they've tried to manage their use, I guess there's that roller coaster kind of process when they've got a relationship with a substance that can itself be a concern. So I guess in the short term, I'd like to know what he thinks the alcohol is doing in terms of supporting his management. If that's how he sees it, I would engage him in conversation around that. Because definitely alcohol is known to, particularly dependence, is known to be a risk factor for suicide.
Yeah, okay. And we're going to go on, as I say, shortly and talk about management, both sort of short and longer term, and presumably addressing his substance abuse is going to be important. This one's a bit out of the blue, but it's an interesting question that one of the participants sent in, so I just wonder whether you, Carmen, or Grant would like to pick it up. And that's, do we have any data on a genetic predisposition towards suicidality? Grant, your picture's on the screen, so I'll throw to you. Do you know anything about that?
As an excellent GP, I'm going to immediately refer it to Carmen. I have no idea.
Do you know anything about that, Carmen?
Yes.
Do we have any evidence for genetic vulnerability?
There is evidence. Yeah, there's evidence from the twin studies, and it's roughly 50% variance accounted for genetically. But I think what's also important is people's experience and exposure. So in terms of family history, I think that's a greater contributor to people's experience of suicide. So while there is a genetic predisposition or a genetic component, and that's apparently in line with the serotonergic system, and there's a whole lot of other stuff here that we look at, to treat genetic factors is very difficult, whereas we have the ability to actually work, and forgive me, there might be some treatments out there that are looking at genetic management, but my understanding is that we're well off that yet, and that working with exposure points to suicide within a family context is a much better avenue in for management.
Yeah. Okay, good. Thanks very much. Before we leave the area of risk and protective factors, we do, in this discussion, inevitably tend to focus on risk factors, but I wonder if any of you have any comments that you'd like to make about protective factors. Are we simply looking at the other side of the same coin, or can we say anything more about the kinds of things that will protect someone against suicidality? And I'll leave whoever wants to jump in there. Or maybe I'll... Yep, was that you, Carmen?
So, yeah, it was. I was going to say, in terms of protective factors, I don't know that there has been research to say that these protective factors are protective factors forever and a day. So in line with that fluid vulnerability kind of process, there are some things which are protective for a period of time, but they may not stay protective. So, and also in line with Joiner's theory, the theory that if you're connected and if you feel supported and you can reach out for help, that's obviously protective. But there are certain conditions for certain groups, for example, people in refugee camps where they are connected and they're not a burden and yet the suicidality emerges in that. So again, we have to come back to it's a far more complex process. Much of the protective factors that have been identified are actually more about mental health rather than suicide specific. So protective factors are only protective factors when they're assessed to be protective factors, and they may not be in every circumstance at every time, which is a really not very helpful response. But yeah,
but it's a very important one, yeah. And I do think everybody would like to have some nice firm information about protective factors, but I think those notes of caution are actually very important, that it isn't as simple as it might at first sound. And well, I don't want to go down the tangent of resilience, but that's another one that I think is potentially fraught with difficulty. Let's move on and talk a little bit about assessment, assessing suicidality or suicide risk and so on. And most of you, I think all three presentations, have kind of addressed this to a certain extent, so we'll make it fairly quick. But I wonder if I could perhaps turn to you, Richard, and ask, look, hopefully this is not something that's common among health providers, but there is a broader concern in the community that if we ask about suicide, we might actually be prompting people to do it. Do you think does anybody need to be concerned about that, or should we be reassuring not only providers but also friends and colleagues that it is okay to ask?
I mean, I think it's absolutely okay that, like everything, it's the way you ask it and the empathy, or the honest inquiry that you make, and you must be seen as curious. It's very easy to be seen as just going through the motions. Using the word suicide, it's not a problem. I often feel if you use more common sense phrases like asking if life feels like it's a net loss equation, or if you're feeling overwhelmed, or those questions I went to earlier in the slides, rather than asking about suicide. But we can normalise it by saying that many people in this situation would be feeling overwhelmed and that life isn't worth living, and then express a curiosity regarding that. And just asking the question in a number of different ways across time. I'm mindful of risk assessments because I think they're only as good as when the person walks out the door, and any dynamic factor can change. And so the caveat to that assessment would be to focus on rapport and trust, and ideally that the individual will be seen regularly, knowing that if there's any concerns that they can contact you during the intervening period, and that you've followed up with a phone call to the GP, anyone else. Not to disclose any confidential information. It can be a bland statement, but just asking for increased follow-up and express some concerns. I am not a huge fan of codified assessment tools because I think they come across as a little bit dry without the empathy that the person needs. And often what saves lives is an honest discussion and letting that person know that you're there with them. And we may not know exactly where we're going right now, but we're doing it together, and we're just going to care for their needs and take it an hour by an hour or a day by a day. And then when things settle, we can start planning for greater periods, week ahead, month ahead, and so on.
Yeah, absolutely. And yeah, go on.
Mark, may I ask a question in relation to Richard's comments and Carmen? I'm just wondering, I imagine that a lot of the brief suicide assessments are going on in GP land every day, and I'd be really curious, if I may, for Carmen or Richard to comment on what would be some absolutely key questions for our GPs to ask, usually in a pretty short time frame, to help them try and prioritise how much risk there is and whether or not they need to escalate things.
Carmen, do you want to take that one first?
Well, I ask the question quite directly, and I would ask it in a way in which most people would have the thought. So people don't say, I think I'm going to suicide. People usually think I'm going to kill myself. And I guess my experience with veterans and my experience with police and firefighters and all of those first responders they're quite black and white. And so they're not frightened of receiving a question like that. But if I don't have the rapport there, then it's very hard to ask a question and expect them to give a genuine response. So I would be using the cues that they are giving me and the responses that they have in order to be able to ask that question. But I would certainly be asking, are you thinking of taking your own life? Have you had thoughts that you don't want to be here anymore? And then allow their response and how they, if they avoid it, I'm curious to know, you seemed uncomfortable when I asked that, and allow the conversation to continue. I think what's critical, though, is that people aren't stuck on time when they're asking these questions, that if it's going to take 15 minutes, it's going to take 15 minutes. If it's going to take 25 minutes, it's going to take 25 minutes. But we have to have, we can't be satisfied that we've asked the question and they've given a response. If there's something in their response style, their body language that says they're not sure whether or not they should answer that.
And do you think sometimes that clinicians, and you might comment, Grant, about GPs, are frightened to start asking those questions because it's going to open a Pandora's box and they really haven't got time to deal with it? What are they going to do anyway, and so on? It's better just not to ask the question.
Look, I think you're right, and I guess I was alluding to that earlier on, that in some sense the confidence of the GP is partially due to their training, but it also is exactly as you say, Mark. What will I do if they give me information that I can't deal with, or I don't feel I can access the specialist services? I think also to Carmen's point, which I think is a good one, is that, you know, it's going to take as long as it's going to take. But I think as a GP, and GPs are dealing with so much mental health issues, that they've usually got quite a small number of questions that they ask, and typically in the GP notes, for better or worse, it will have something quite brief in there. You know, some suicidal thoughts, no plan. That will probably be a pretty typical bit of documentation, you might say. So it's a constant dilemma in primary care where you've got this huge volume and you're trying to sift the needle in the haystack. But they're very helpful comments.
And what I would say about suicidal thoughts, you can't do anything if somebody's saying, yes, I have suicidal thoughts. What are those thoughts about? What have you been thinking? Have you got a plan to take your life? And, you know, what are the ways that you've thought of? So clearly for Craig, for example, he's had a firearm, but what are the other ways that you've thought of taking your life? Because he's looked at medications. What does he think about medications now? Because that may be something that GPs can manage in terms of restricting access to medications or reduce dispensing practice, have that negotiation with the dispenser, the pharmacy. So I think that in terms of the firearm, so he may be reluctant to relieve that firearm, but there might be other ways. If he does ultimately give it up, there might be other ways which are accessible. So the GP does have, you know, I would encourage them not to be frightened of asking questions because they do have a really, really crucial role in asking that.
I think it's a very important point, isn't it? Maybe someone will say that as a take-home message at the end. Don't be afraid to ask the question. I want to move on to management now, but before I do, and I'm conscious of Richard's comment that he has concerns about sort of tools, as it were, but just very quickly, can I ask you, Carmen, because a number of people have asked, are there any sort of standardized tools that we can use to assess suicide risk? Or are we better off just sticking to a clinical interview?
There are tools that you can use, but it depends what you want the tool to do. If you're looking to predict who's going to kill themselves and who's not, then I'd say there is no tool that can do that. So don't bother using a tool. But if you're looking to find intervention points and strategies, then there are several tools. One of the best, and I'll have a disclosure that I work with Jacinta Hallgood on this, but Jacinta and Diego De Leo have developed the STARS protocol, and I've supported her in some of that. But the STARS allows us to look at safety planning. It allows us to look at key aspects to intervention and treatment plan. It's a really fundamental tool. But if you're not looking to do the interventions, if you're not looking to do treatments, then it might be that you're looking at the Columbia Suicide Severity Rating Scale. But that scale doesn't give you very much except for screening and looking to do triage type stuff. It doesn't give you the intervention. There are some other tools like the Suicidal Affect Behaviour Cognition Scale, which was developed by another Australian, Keith Harris, and my experience of using that tool, and I know that there's a very strong evidence behind it, that it has had some clients go, oh, I don't like the last question. It's asking me to predict whether I'm going to kill myself in the future. And so they've refused to answer that. So you really need to look at what the tool is and what you wanted to get out of it, is my thoughts. There's a couple of others that look to triage people through, and they're looking to categorise ratings. So they're looking to do low, moderate, high. We all know that low, moderate, high is rubbish. It doesn't actually support intervention. It doesn't actually predict low, moderate, high risk. So there's no value in using a tool that does that.
Sure. Okay. But the bottom line, presumably, is that good clinical skills are going to trump everything, really.
Absolutely.
Thank you. Let's move on. Let's move on to talk about management. And if I can come back to you, Richard, I guess we've been talking a lot about the acute management, how we're going to manage when Craig is presenting being actively suicidal. But as we get past that initial danger phase, presumably there's a lot that we're going to need to do with Craig to reduce his ongoing vulnerability. And you talked about a couple of issues. You talked particularly about anger as being something that you felt was going to need to be addressed. We mentioned substance abuse as well. Do you want to just talk a little bit about how you would see Craig's management panning out once we've got past that immediate danger state?
Mark, may I interrupt for one moment?
Please do, Ron.
Yes, so I'm sitting in general practice and we haven't all got Richard. We'd love to have Richard. Can we just talk very briefly about how do I get a Richard?
Absolutely. How do you get a Richard? Well,
we're going to clone you, Richard, and Carmen for that matter. So often for the GPs, you're sort of thinking, gosh, if I ring up, I'm going to possibly get a wall at the CAT team and may or may not get help. I mean, I think this scenario would ring alarm bells, so I think you would get a response. But there's the whole gradation of not so clear-cut people. And so just perhaps if you don't mind as well, just some comment on how you decide when you get a call from the GPs, which ones you're going to chase up and which ones look like they could be managed back in the community. So sorry to jump in with that, Mark, but I've got to wave the GP flag a little.
Absolutely. No, it's a very good point. And let's give Richard a chance to respond to that one and relatively briefly, Richard, but the longer-term treatment issue.
The way I think about it is there's the treatment arm, which is obviously the subjective experience of reducing symptoms, improving function. And then there's the system and advocacy. Many of our veterans clearly are not informed regarding potential liability claims for accessing payment and support from DVA or non-liability healthcare. If someone has served 24 hours or more within the military, you really can throw hot and cold running resources at them. I work closely with a DVA advocate in Western Australia who is a wonderful reference, and I'd recommend everyone having on their speed dial either a local RSL with an old and bold DVA advocate who can give good advice on the day, or that you can plug the veteran into once the crisis is settled and they are able to tolerate a discussion that might have some facts or details or obligations on their part. I also use a lot of peer support. There's a group in Western Australia called Overwatch, national group, who basically are peer-to-peer support, and their remit is to identify veterans at risk and bring them to care such that their disposition can be then passed on and then they step out. So they have a very clear and crisp remit. But it goes the other way. On the weekends, if I'm worried about one of my veterans, there's a stable of ex-service organisations who I will trust my patients with and ask them to provide care to. And veterans will talk to veterans much more freely than they will someone who comes into the house and doesn't really understand their experience. And that can be very helpful. The other arm, independent of medication, is the psychosocial rehabilitation. Now, whether someone's able to return to work immediately or just needs some assistance, having a rehabilitation service, and in Western Australia I use Insight, INCITE. Danielle Murphy and her team are excellent. It's a small cottage industry. They're not a multi-site service. They just capture Western Australia, and they will get assistance dogs. They will organise for money for the veteran to go fishing, for equine assisted therapy, for anything that's sort of out of the box that the veteran might want to do. Again, that normalising and validating the person's experience, because unfortunately the medications that we have might dampen the arousal states, but that really only helps get the person to the space where they need to work on more resources and skills in anticipation of doing the necessary exposure work, plus or minus eye movement, desensitisation, retraining, physical education, psychoeducation, and so on. It's important we have a streamlined pathway of affiliates or a small stable of people who are competent with veterans or who know veterans' health well, who will be taken seriously by a veteran in crisis and can respond rapidly. not overstep their remit, but also plugging the veteran into psychosocial services that, again, can give them a sense that there's a group of people wrapping themselves around that veteran who are taking their distress seriously, but are maintaining a sense of hope and optimism that, yes, we've seen this before, you're not the first person experiencing this, and we'll help you through it like we have with everyone else. That would be the sort of the key message in terms of treatment modalities before getting down in the weeds about what medications when. But for anyone in Western Australia, I'm more than happy to be contacted. I have no problems with that, and I don't mind you guys providing my email details after this forum. I'm very happy to do that, and in fact, I think that's what we should all be doing. It frustrates me when defence do it one way, Army do it one way, police do it one way, and so on. I think there should be an open source of shared information so everyone's learning from one another, because we all have lots to learn from each other. I mean, I've learned a lot more from nurses and GPs and the like than I have from any textbooks.
It's a very generous offer you've just made there, Richard, and I hope that you don't get too inundated. But I think it's a great thing to do. It's raised a number of issues. I think, can I just mention, because I'm not actually sure where it's at the moment, but Phoenix, Australia is about to start, as far as I understand it, a DVA-funded health professionals advice service, so that they will be able to link in GPs like yourself, Grant, with a number of psychiatrists around the country and clinical psychologists and a range of people. So hopefully that will go some way to solving it. There are a whole range of issues I wanted to pick up there, Richard, from what you mentioned, but can I just pick on one at the moment, and that's the peer support idea, which I think is really good and really important. But I would like you to comment on whether you think there are any dangers to it in terms of, I guess, boundaries, and in terms of the kind of pressure that peers may be put under, and perhaps they who don't necessarily have the protections that professionals might. Could you just comment briefly on that?
It's an excellent point. One thing I wish very much for DVA to take on board, and if anyone's listening, I'm happy to have that conversation. There's a sea of retired chaplains who may have been medically retired, who still have an interest in providing chaplaincy for veterans, and they've spent their life going into people's houses, sitting with them over a cup of tea, and it's not appropriate that myself, a nurse or a psychologist does that, but a chaplain or other retired medics and so on can do that. There's lots of ex-service organisations, and obviously, like everything, we're all just people, and some are more and some are less sophisticated in the way they practice. But over the last 5 or 6 years, I've developed an affiliation with a number of the ex-service organisations through VVCS. Twice a year they have a consultative meeting where everyone gets together and you just get a sense of who the good operators are. And clearly you wouldn't expect anyone to put themselves in a situation of risk, and that needs to be clearly articulated. But an intervention where the risk of not doing anything is greater than the risk of offering help, you have to think about these things, and often they will go in there with police or an ambulance if needed. Overwatch operate exclusively in these situations. They send me more patients than I ask them to look at over the weekend. I think Overwatch set the trend, at least in Western Australia, for robust, vigorous care of veterans.
Yeah, that sounds great. And you also alluded very briefly there to some dog support. I hate to call it dog therapy, but dog support. And we're certainly getting a lot of comments from participants about animals, about horses and dogs and so on, and I guess also that can be very valuable for people. But I think it sounds like the take-home message really is about making sure that we're linking in with a support network of professional and peers and so on support, so the person feels protected from feeling so isolated, perhaps at times of suicide. Thank you very much, Richard. Can I just ask briefly? Another point that you raised there, and I want to throw this to Carmen actually, and I know it's a bit of a minefield, but the issue of employment, do you see in a case like Craig's that it's important to assist him to be getting into some kind of meaningful employment, something that's kind of going to give him some reason to get up in the morning, some kind of worthwhile thing?
Yes, I do. I mean, certainly in terms of his management, he has to have the medical management in place, and he needs to have, I guess, some of that. And it's hard to tell from Craig's story what's going on, but and what he's received prior to medical discharge. It may be that he's been engaged in occupational rehabilitation and that he's had medical management, and they've attempted to get him back with the same employer. But post-medical discharge, Defence no longer look after that, and they go through to DVA, and so they manage the rehab. So as well as looking at increasing his functional capacities through treatment and that sort of thing, I would be recommending some of that stuff around what options does he have from a vocational perspective, his identity. And I think this touched very much on what Richard was talking about, that transition stuff. What can you do after military service is over? What are the transitional skills? Looking at vocational assessments and matching those transitional skills with interests and capacities. So that sort of work is important in terms of rebuilding how he identifies himself as a breadwinner or as a partner, as whatever it is that's important to him. So certainly it's part of a recovery orientation, but when he's ready and when he has that capacity. And I guess functional assessments and psychological functional assessments are very important in doing that. One of the concerns that I have is sometimes that the psychological component to a physical injury is missed. And looking at some of the risk factor warning sign stuff, risk factors of physical injuries is one of the, has been identified through a lot of research, including military research, that is a risk factor for suicide, and it can be over and above that for psychological symptoms. So whenever we're looking at a physical injury, we need to be mindful of that psychosocial impact and I guess incorporate that potentially into short-term interventions. But equally, it may be that if we don't address it in the immediate term, that it becomes a long-term psychological problem.
Yeah, I think it's a very good point. And I think DVA currently is doing a very good job in terms of its rehab assessments when someone is taken in for rehab for a knee injury or whatever, of making sure that they are also asking about psychological, social functioning. So it's a very good point you make. I'm looking for some quick responses now because I want to move on to some other areas. But Grant, can I just quickly ask you to do something of a plug for Beyond Blue, really? The recent federal budget, I think, allocated a fair bit of money to something called the Way Back. Just briefly, can you tell us something about that?
Well, the Way Back support service, it's actually led by Bella Burns at Beyond Blue, and we're very pleased for massive federal funding, really, $37.6 million over 4 years, focused on particularly post-discharge after a suicide attempt, particularly in those first 3 months. Very intensive follow-up, non-medical, but with either face-to-face or phone or texting, making sure people go to their appointments. Very practical support. If they need Centrelink work, helping them to get employment, all sorts of this thing. So far, before the funding, there's been over 1,600 participants at 6 sites, and the early findings are that it seems to be working really well. So we're very excited about it, and in Brisbane in particular, there's some work with veterans and with DVA, and I think that Brisbane site will be a really interesting and helpful model for vets. So thanks for letting us mention that, but I think it's very relevant to people out there.
I think it is very relevant, and I think it's a great initiative, but I guess it's also not too dissimilar from the kind of stuff that Richard was talking about. It's almost like an intensive case management kind of model, isn't it, for sort of a while, through a range of areas of functioning.
Yeah, as a GP, I mean, part of the problem is I get these patients back. We're a big bulk billing clinic, and those first few months after a suicide attempt at hospital, they invariably get lost to follow-up. And I think the stats say about half of them get lost to follow-up, and of course they're very high-risk group of trying again. So hopefully it will make a big difference.
Okay, thanks. I'm going to just chuck this one out there, and I'm looking for very quick responses. And if there's no responses, that's fine by me. But a lot of participants have sent in questions around this, and that is social media. Social media, the good, the bad, the ugly. Does it prompt suicide? Can it be used as a suicide prevention kind of strategy? What do you think? Suicide media, discuss. Social media discuss.
Great, you've got the Beyond Now app. But otherwise, I was going to say, in terms of social media and that sort of thing, I think it's easy for us to pick people up via social media, but it's not one of those things that I want to be having a conversation in an open forum. Certainly not one of those. So if I see something, I'll take it offline in terms of identification. So, and I understand that there's also metrics and that sort of thing in place that are picking up on suicide risk without being overt in saying, I'm going to kill myself. They're picking up on those individuals who are coming across a metric. So, Richard or Grant?
Yeah, we at Beyond Blue, we have a very active online forum. There's sort of 8,000 posts a month, 100,000 people looking every month. And we recently commissioned some research looking at discussions about suicide. And there's a lot of peer support from champions, and the whole site is carefully monitored and filtered by our team who read all the posts. There's a sort of a desktop that checks anything at risk. So it's sort of a safe place compared to the big, wide, horrible internet out there with trolls and things. So I think people should be aware of the Beyond Blue Forum as a sort of a valuable place that people can talk and speak to others who are going through similar things.
Good. Okay. All right. Thank you very much for that. It's this horrible time where I can see the clock just ticking over. I've hardly got any time left. There's things I want to get through. I just want to talk quickly about families. You mentioned the importance of families, Richard. I guess they are a very important component, both in terms of involving them in looking after the veteran, but also we need to be looking after the family. Tough time for them, presumably.
Oh, absolutely. And I champion VVCS for this. There's no doubt that if someone is emotionally dysregulated or having problems with their affect tolerance and being angry and agitated in the eyes of children or their wife, every man's going to feel shame and guilt around that. One of the other services that I link veterans into is a group that does some circle of security work, attachment and bonding between the father and the children, because dads know they don't want to be irritable, intoxicated, arguing with the mum. There's not a man who doesn't feel bad for doing that afterwards. And so thinking of the person within their system and linking the other family members into resources is a really good idea. And just for simplicity, VVCS does this as well as anyone else. I think they probably do it better with children, and they're working hard on that to have dedicated services to help kids understand what PTSD is. There's also a very good book called Operation Greenheart, which is an Australian book you can buy online. And it explains, it's not the only book clearly, but it's one that I think is quite readable for young kids. I give it to the dads to read and then give it to the kids if they're happy. And as an example, it gives the child an understanding through the child's eyes of what anxiety is, what it is like for a dad or mum to be experiencing high states of arousal and fear. And just recently, a young girl, she helps her dad by giving him a hug before every time he leaves the house, which is just delightful. And, he gets quite emotional when he talks about that change in the family dynamic. It's something simple, but it's a big change in the way he's relating to his daughter. And that can be built on over time. I'd encourage everyone to link in with VVCS very robustly if you have family members of someone having a hard time, because then they'll all prosper and close ranks and ideally help the veteran further.
Good. I certainly support that, Richard. I think VVCS does do some great work with families, and they should be the first port of call. I'm conscious of just throwing this in at the end, and we haven't got time to discuss it, but I do want to come back quickly to looking after ourselves. And I think I'll throw to you, Carmen, but get others to jump in. Just very briefly, what you see as being the key take-home things about how do we look after ourselves, and particularly bearing in mind Richard's slide about the fact that however good we think we are, we're not going to be able to do it every time. Can you just comment a bit, Carmen?
Yeah, I think that being real about what we're working with and that it does have an impact, and if we didn't care, then it wouldn't have an impact, and it's because we care that it has an impact. But there's stigma around how we can manage it, and a lot of the work that I have done, a lot of the contacts that I've had is with psychologists, particularly, who are frightened of saying, I myself have had thoughts of suicide after the loss of my client because I'm just not good enough. And I think that as practitioners, we all have to acknowledge that sometimes this stuff gets really tough, and not necessarily having suicidal thoughts, but if that was to come through, that we have to be able to access support ourselves. We can't fill up other people's cup if our cup is empty. And there's lots of ways that we can look at how that that happens. But if we're working with 100% client load of acutely unwell people and we're taking calls all night, we're not sleeping, we're not eating, we're not socialising, doing the stuff that makes us feel good, then we're not the
no use
therapist
to
that
anyone
we would
else.
like to be.
Yeah, exactly. Do either Richard or Grant, I've got 10 seconds to comment on that, or anything you wanted to add?
I've got a quick point, Richard. I mean, I think for GPs, you know, managing boundaries of this infinite pot of human misery is really important. And, you know, if you're in primary care, the sheer volume of people and, you know, the risk of trying to be heroic is always there. Last thing to mention, there are a lot of doctor support services out there for people that are having mental health issues, which I won't list them all now. Perhaps we can online.
Yeah, great. Thanks, Grant. Do you want to make any comment about that, Richard, as long as it's very brief?
No, just share the risk. Involve as many people as you can.
Yeah,
good point.
You don't want to be carrying these things by yourself.
Yeah, absolutely. Very good point. I quite agree. Yeah. Okay, look, I'm really sorry that time just seems to go so fast in these things, but time is running out. So before we close, I would like to give our panelists just one more chance to give us some take-home messages. So just some quick messages that you'd like to leave our participants with, and I'll turn, I think, first to you, Grant. Just any key comments?
Simple one, and particularly as a GP who didn't know that much about this, is to get informed. There's a lot of services out there, and hopefully this has been part of that.
Great. Thank you very much. Carmen, any take-home messages from you?
Mine is just that people can and do come through suicidal thoughts and suicidal behaviours to lead really meaningful lives. I think people sometimes can lose sight of that when they're sitting in the hopelessness. And I think also that there's psychosocial environmental approach. It's not just about medication or treatments. There has to be a wraparound community approach. Yeah.
Absolutely. Richard, any final comments from you?
Just two things quickly. In terms of CPD points and so on, BVCS and other ex-service organisations will happily visit you in your practices. They'll sit down, have a cup of coffee with you and tell you what's in your local environment and help develop a pathway to from sort of referral to disposition planning for someone in crisis. And if anyone wishes to travel, I'd strongly recommend going to the Stand Tall conference, which Tony Dell does every year in the Eastern States. It's an excellent conference. They bring some really high-ranking speakers in, and it really is a good way to meet all defence, veteran and first responder organisations and spend a couple of days with internationally renowned experts talking about all of this stuff. It's a lovely, lovely couple of days.
Good. Sounds great. Thank you very much, Richard. Thank you very much to all our panelists for their input tonight, and I just apologise again for having to rush through it a little bit. Before we go, there's just a couple of other things that I'd like to draw your attention to. The first is that MHPN supports practitioner networks around the country where professionals from different disciplines can get together and have a chat and support each other and share resources and share CPD and so on. And recently, or relatively recently, MHPN has started veteran-specific networks. And you can see on your screen there that there are veteran-specific professional networks in those areas. If you would like to start one, by all means contact MHPN and they'll give you a hand. Otherwise, I think in your resources, when we talk about resources, there is a join a network sheet that you can fill in, and MHPN will help you out with that. But it's a great thing to be involved in, particularly if you're a little bit isolated in terms of your clinical practice. In terms of resources, there are a whole range of resources that will be available after tonight's webinar, and MHPN will send you a link to the resources. A whole lot of good stuff there. I always give a bit of a plug to the DVA at Ease website, which has got lots of stuff for practitioners, for veterans, for their families, and so on. But there's a whole range of other stuff, and if you check that, when you get the link, you'll be able to access all of those. And finally, I would ask all of you to complete the feedback survey before you log out. It really is important to us to know what you thought about tonight and so on, and to help us guide future ones. So please click the feedback survey at the bottom of the screen. And as it says on the slide there, you'll get attendance certificates, you'll get the links to the resources. But for now, I would just like to say thank you very much indeed to everybody for joining us. A particular thank you to our panelists. I thought the content of the contributions from our panelists was brilliant tonight, and I thank you very much indeed for your time. And I thank all of the participants very much indeed for joining us tonight. I'm really impressed, not only by the numbers, we had over, I think, 1,200 people logged on, which is an extraordinary number, but also by your engagement and so on. It really makes it a lot more fun and a lot easier for us. So thank you all to our participants and our panelists, and well, good night to all.